But regardless, thank you so much for coming today. Nice to see you. We have a warm group within the space here, so I hope to provide you with a little bit of information. I start with a caveat that I am not an expert in diagnosing maltreatment towards our children. What I do have is a skill set and a knowledge base that helps me understand how systems in our state can work together better and stronger to create overall health and wellness for our families. So today we're going to look at this presentation from that lens of how can we, as an attorney, as a doctor, as other medical professionals, join together to create resilience for our families as well as better systems of interprofessional response. The Center for the Prevention of Child Maltreatment was established in 2017 after a 2 to 3 year work plan that was put together by a group of people who made up Jolene's Law Task Force. Jolene's Law Task Force looked at child sexual abuse in South Dakota. That task force spent 2 years being legislatively funded and supported to say, how can we as a state better come together to respond to instances of child sexual abuse? Not only did they look at child sexual abuse, they looked at child maltreatment as a whole, knowing that abuse does not happen in general one category at a time, and we must be prepared to respond to multiple harms against children, and quite frankly, multiple impacts as well. So the result of Jolene's Law Task Force was a strategic plan for South Dakota. How can we come together as a group to really impact our state? We rest on three pillars. What do we know about? What are our best practices, our evidence-based practices for knowing about harms against children and how we can respond to them? How do we respond with early intervention and healing? And then how do we work to prevent those harms from happening? So today, like I said, we're going to talk about our multidisciplinary lens. We're going to talk about our multidisciplinary approach. We're going to go ahead and start with a couple of case scenarios. I'll call them fact patterns. Here's my trigger warning for you. If anybody online or in the room needs to step out, we will be talking about hard topics today. It is April is Child Abuse Prevention Month. This is a pediatric grand rounds dealing with child abuse. I assume that you knew coming in that this would be a topic, but if you are surprised, if you're online and surprised by this topic, just know that it's okay to step away from the computer, and there are resources for you should you need them if this is triggering for you. Make sure you always reach out to 211 for support if needed. So we're going to go ahead and start with 3 different fact patterns. Our first fact pattern is a child, age 4. The child is brought to a medical facility and is severely malnourished. That child is underdeveloped and has multiple fractures. The child is known to have spent quite a bit of time in a high chair to the point where the wall behind the child has an indentation where the head was resting against the wall from that high chair. And the doctors determined that the child would have died with injuries within hours to days if that child had not been intervened. As a prosecutor and as a law enforcement officer, this looks like we need an instant intervention, and that there is going to very likely be an instant complaint against the perpetrator because of some of these harms. Well, as we go through the case, there's some more information that was presented to us. The child was a victim of, was a shaken baby early in life. That led to severe behaviors that could also be co-diagnosed with an FAS diagnosis. The child's family was not able to care for them, so an auntie took in that child. The aunt had 7 additional children in a 2-bedroom home, and they were trying to live together in that home. The reason the aunt had so many children is because the family came together surrounding that one stable environment, and that was a way to avoid interaction with child protective services at that time. When there was an intervention by law enforcement and the children were taken out of the home, it was found that every single person in the home was hungry, the adults included. The main perpetrator, the aunt who was the individual who was responsible for the care of this child, gained 20 pounds while in custody. She was severely malnourished. And then the child was diagnosed with deprivation dwarfism, and an unknown disease that caused brittle bones. So the child was continually being hurt by walking, going down a slide, changing diapers. And so there was more to the story. The second fact pattern, child, age 6 years old is our victim. The brother of the child tells mom, my sister, mom, your boyfriend's been bunnying my sister, my younger sister. There's a 911 call made, an ambulance ride for the sister taken to a hospital, and at the hospital there's a physical exam given to the child. What we come to find out, again, this appears to be an instant reaction by law enforcement, emergency medical service providers, and even the folks at the hospital to provide that exam because they hear the words, there's a sexual allegation of a sexual abuse. But what we come to find out is that the mother was actually in custody for 8 months and the boyfriend was the main caregiver for the children. When the rape occurred, which is what the bunnying was, there were 2 children on the bed, the boy and the girl. And when the act was done, the perpetrator would leave coins on the bed and walk away. The brother told multiple people, an older cousin, a teacher, grandmother, and the first response that happened when the boy said the words out loud was when the mother got out of custody and called 911. And the response was an ambulance ride months after the abuse had occurred. So we're gonna go to the third case. Third case, child, a baby. Child was co-sleeping with mother. Mother was intoxicated and baby is found deceased the next morning. This is interesting because there was not an indication in the autopsy report at that time of whether or not this could be a full suffocation or a rollover. It was not ruled a SIDS because of the circumstances, but it was an unexplained death. And there was trace alcohol found in the baby's system. This information, if it was released in the newspaper, many of us would automatically think that mother is just horrible. That mother has harmed her child. When we look at this, the mother has a history, her own history of physical, sexual, and mental abuse. She was raised in institutions, in boarding homes, and in juvenile detention centers. There was no furniture in this home but a bed and a car seat. The car seat was provided by the hospital. The entire support system for the mom was engaging in alcohol the night that the baby died. And the baby and other children were back in the bedroom, actually what the family viewed as a safe place, away from the alcohol, back in the bedroom. And then we came to find out that the alcohol in the baby's system was from decomposition, not from ingestion from the breast milk. So what do all 3 of these horrible cases have in common? The first was a lack of a coordinated system for assistance. And I'll be frank to say, it was the lack of the system, perceived or a real lack of assistance. It could have been that the family didn't know how to get to assistance, or they didn't know that they could get to assistance without getting in trouble. The second major piece is that the medical multidisciplinary team member was the key component to each of these in determining how the case should proceed. It was essential that there was a consultation with a medical provider who could show a true picture of what was potentially happened to this child and interact with the prosecutor, the law enforcement officer, and child protective services in a way that we could see what was happening. Now, I'm going to go through each of these a little bit differently because the prosecutor relied on the team for charging and sentencing. You know how I know that? Because I was the prosecutor. All 3 of these cases happened when I was in my last trimester of having my first baby. And the reason I'm at this job is because I was reviewing these cases. And of course, cases take a long time. So some of us happened while I was pregnant and some of it was while I was on maternity leave. And I remember holding my first child and rocking her and thinking about specifically this first baby, the male, 4 years old, and saying, who's there to love that child and to rock that child? Why was that family hungry? I go to this second case fact pattern. So why was an ambulance called? Why was there a medical procedure done on a child when a few short conversations with that family could have determined that the harm against that child happened months prior? You could have determined that there's potentially a human trafficking case here with the exchange of coins for services. Could there have been some other interventions for that family? And how could we have supported that mom who was in custody, who is the first advocate for the child? Did the teacher or the cousin or the grandma know how to report alleged abuse? And if they did report alleged abuse, what were our community-based responses? And let's go to that child number 3. This is a tough one. This is a tough one, because in this case, I had a medical provider. I had the person who performed the autopsy say to me, what good is it for me to diagnose a child with SIDS? What good is it for me to diagnose a child if I don't know the exact cause? Because what's that going to do to the parent? And there was a back and forth conversation with that medical provider where we were able to say, here are the circumstances where we came to the decision that we could prosecute that case, and there was some harm. This mother received an 8-month sentence, 4 months for home confinement, 4 months in custody. And the judge looked at me and he said, what else should I have done to her? What else could I have done? She unintentionally, without knowing any better, killed her child. What else could I have done? And that really made me realize, these series of events made me realize we as society have to do better. We can do better for our children, our families, and our communities. So the first time I heard about average childhood experiences, or ACEs, I was still in my role as a prosecutor, a new mom, and I said, we have to bring this to South Dakota. We have to be able to do something better. I didn't know then that it was called a public health approach. I know now, but we have to do better to work together as a team for our state. We're lucky that Jolene's Law Task Force, we actually have some key founders from that task force in the room today, led to the Center for the Prevention of Child Maltreatment, and I felt a calling to come and be part of the change. So I hope that our messages today lead you to really think about how you can be a part of the change as well. A public health approach, especially one that's dealing with children and child welfare, is an approach that promotes the healthy development and well-being of children. It builds off of the public health model used to tackle complex social problems. As described in our 3 examples, these are very complex problems. This model focuses on prevention and support for the community-based change. The Surgeon General of the United States connected this model with child maltreatment as early as 2005. So we are 20 years post this model being used for child maltreatment as a best practice. The Center for Disease Control and Prevention also champions this public health approach around the reduction of child abuse and neglect. And they define 4 steps, which is, how are we knowing about the problem, defining and monitoring it? What are we doing to identify the risk and protective factors? And then once we do that, what are we doing to actually implement changes into those risk and protective factors as prevention strategies? And then how do we together ensure widespread adoption? And what I think is so brilliant is that the strategic plan for South Dakota set up for child maltreatment follows this public health approach for how we can work together as an MDT or a multidisciplinary team across our communities to really bring that widespread approach. So we know that the child welfare system is not a single entity. Most organizations in each community work together to strengthen families and keep children safe. Child welfare systems are as complex as the problems that we're trying to approach, and their specific procedures vary widely by state. Child Protective Services remains a critical component of a public health approach in order to respond quickly when children are at risk of serious harm. But CPS is only one part of the system. Other systems that are key partners include the courts, law enforcement, medical communities, mental health, public health, and education. Even neighbors who come into regular contact with young children and families are a part of the public health approach. each have a role to play to ensure that help is available when the family needs it. And that help comes through services and support such as prenatal care, health services, evidence-based home visiting programs, employment, education, parent partnerships, housing support, early childhood education, parenting skills training, substance abuse, mental health treatment, and domestic violence programs. It is a complex but important system that we all work together. CPS as a 21st century response team will continue to be important in how we create safety for our children. But the ultimate goal is that fewer families will need involvement with child protective services. This will free up our child protective service agencies to respond with more in-depth support to every child who comes to their attention. As a result, child protective agencies will be stronger and their case management teams will be more effective. They will have more multidisciplinary partners with better connections to professionals in our communities to help our families. And our community-based partners will be ready to step in to support the family when CPS is not able to. This audience is very familiar with adverse childhood experiences. Is there anyone in the room or online who has not heard the term adverse childhood experiences? What I'll go ahead and move through then is just tying in this friendly reminder that when we talk about adverse childhood experiences, the initial study done by Kaiser Permanente and the CDC with Dr. Anda as one of the original PIs for that investigation, looked at 10 instances of adverse childhood experiences. But let's be cognizant that trauma can happen to children in multiple different ways. And when a trauma that overwhelms a child's ability to cope comes out in physical manifestations or in their behaviors or in their actions, we together as a team can say, what can we do to create the safety around that child to end some of those harms? We know that ACEs have lifelong and lasting impacts. So you as a professional, if you are really, really engaged with trying to figure out why there is too much use of an emergency room or too much use of going into a jail system, if you see that medical costs are too high or housing costs are causing issues or you're invested in daycare issues, all of those can be, not always, but can be tied back to adversity in childhood. When we create supports around a family and a child who's experiencing adversity, we may be able to positively impact all of those lasting, those potential lasting issues. Now, I want to be clear here that an ACE score is not a determination of how your life is going to end up, but we just know statistically that the higher rate of ACEs means that you're at a higher predisposition for some of those social and physical issues, which is why we're taking the public health approach. What I want to be clear here is that when we look at our departments of education, social services, health, our unified judicial system, and other service-based departments, and they're looking at key issues such as mental health and suicide, drug use, and again, overpopulation in the court systems, a prevention effort is looking at ACEs because they are directly related. What does this mean for the state of South Dakota? I will tell you, and I'll be really frank, it's hard to put a number on the amount of people who are experiencing harm in childhood without resilient factors to move beyond that. But what we do have are a couple of different scenarios where we've collected some information. In South Dakota, over 8% of our adults, and it varies between 8 and 9, depending on the year that the information is collected, have an ACE score of 5 or more. We're looking at over 50,000 adults who, if we go back to this other slide, are significantly, without resilient factors, are significantly more likely to have issues with suicide, alcohol, mental illness, and illicit drugs. Our children are facing harm at rates that exceed the national average now. Previously, we were on par with the national average, and we've now surpassed that for the last few years. We are also seeing that our death rates from abuse and neglect are higher than the national average. And that is something that we as South Dakotans must pay attention to. 21% of our children, by demographics alone, this information is based off of demographics, are in a position to have an ACE score of 2 or more before life has ever happened to them. Please pay attention to that as pediatricians and community-based members, because this is something that you will be seeing in your practice. I'm heading the wrong direction. Here we go. I'd like to tell you a little bit about the numbers that Child Protective Services receives. And again, we'll go into a little bit more detail about numbers. Numbers are tricky for us because, as many of you know, if you have done research in this area, the numbers are hard to compare based off of the data source. But Child Protective Services is a good number for us to start with, because in the state of South Dakota, if you report abuse and neglect, or if you report a harm against a child, we engage in what we call a centralized intake line. So it doesn't matter at this point in your reporting, it does not matter who the perpetrator is or what the harm is. You call the one number and they will figure, the Child Protective Service Agency will route your call to law enforcement or CPS as needed. And in 2021, they received 17,000 calls. Now, of those calls, a little over 1,500 of them were substantiated cases of abuse and neglect. And this is where the numbers get tricky. I want to be very specific here. Substantiated cases by Child Protective Services means that the perpetrator was the parent, guardian, or caretaker. The kiddo was injurious in the home. If the perpetrator is somebody who is not parent, guardian, or caretaker, or the harm occurred outside the home, they were able to mitigate the harm, then there may not be a substantiated abuse. So when we look at these numbers, statistics show or tell us that it is more likely, as practitioners of the public health model, that we look at that 17,000 number as the number of harms against children versus the substantiated Child Protective Service cases. Now, that does not mean that CPS numbers are invalid. They're very good and strong numbers. They just serve a smaller population of children for a very specific purpose. If we were to do the same exercise and take a look at DCI numbers, we would see a much higher rate of harm against children. And that makes sense because the perpetrator could be anyone. That could be a criminal penalty. However, DCI numbers do not include any information from our 9 native nations. CPS numbers only include information from 5 of our native nations. There's a wide range of data missing, but this gives you an idea that we're looking at a large population of children that need us to not necessarily know what their ACE number is, but to know that trauma can happen and that adversity can happen, and we together will be their safe, stable environment to help them heal. So we talked a lot about that strategic plan for CPCM, or the center. It originally started with 6 goals. After a strategic plan review at 2.5 years, we refined that a bit, but let's take a look at our public health approach developed for the state of South Dakota and how we're going to fight child maltreatment. We base all of our approaches in the CDC recommendations for strategies and approaches for responding to and preventing harms against ACEs. What I think is fabulous is that Jolene's Law Task Force aligned their strategies unknowingly with what the CDC was recommending, because it is best practice. So when you see these strategies within the 10-year strategic plan, know that this not only was brought to you by South Dakotans who have their boots on the ground and are working this every day. It's also brought to us by national and international standards that tell us this is how we together can help communities respond. The first goal that we're going to look at is our data. What can we do better to know about and respond with the information that we have in the state of South Dakota? In 2021, the Department of Education sponsored a large-scale initiative for the center to look into data in South Dakota surrounding child maltreatment. The aim of this is to understand better what ACE information is available and how we can then create a surveillance structure that ensures the capacity to collect the currently available, publicly available data, and then increase that surveillance structure. This initiative allowed us to run a focus group of professionals who use data in South Dakota and say, what is What are your concerns with this? With the publicly available data? Are there areas that we can improve? What's going really, really well? The outcome of that focus group led us to some really interesting key findings that included there was a perceived lack of information out across the state, where the reality was most people just don't know where to look to find some information. And then the second piece of that is the overlap of the information between systems and what is it truly telling us about our children. Another thing that happened, I believe I just talked about the focus group. There was a survey of there's a focus group of epidemiologists and a survey of providers. And the very first publication of that report is available. If you'd like one, take your hard copy. But the very first publication goes through the publicly available data in the state, as well as holes in the data collection systems. And it recommends the following next steps. First, that we as a group, and this is where I need your help, and this is where I promise I'm not the expert, but I'm just going to tell you the idea and you as the expert can take it and run with it. We as a group need to do better about having coordinated indicators across our research platforms and across our data collection platforms. If you are engaging in research in this area, take a few moments to look at what your partners in this field are doing and say, can we create standard indicators with parameters that are similar in ways that our information could be shared or our information could be analyzed against other data sets. And I'm going to come back to this one in a second. But the second recommendation in this data initiative is how are we linking, for example, information from the Department of Health with information from Child Protective Services in a way that gives us overall holistic health for our children, where we can actually say, if we see indicators on a health side or a medical side, and we see indicators out in a public service side, where do they link in ways that we can have better responses for our children? There are two different options for this next recommendation. And first is, we in the state do not have strong data sharing agreements. And it's not that they don't necessarily exist, it's that not everybody knows that they exist, one. And then two, they're not standardized. Now, when we say standardized, I'm not looking for everyone to be exactly the same. But if we can fit within similar parameters, that would allow us as agencies to combine and share information. And then not only that, but to put it in usable terms so that three different sets of people can use it. Our researchers, our public policymakers, and our general community members. The other thing that we found is that there's a high amount of restricted access data in our state. There are a ton, there are a lot of agencies that have brilliant information, but it's not necessarily available to the public, or the public doesn't know how to do the open government information request to get the information back out. So if I was, for example, leading an initiative to increase daycares in my community, how would I get the baseline information to do a needs analysis for my community without knowing where to look, how to access the restricted data, and how to link that data together? And then finally, we need our government, our public agencies, and our legislators and policymakers to respect the fact that we need to invest in a data infrastructure. It's going to take a lot, and we need to show the importance of what we're doing. What I would like to do is, if this works, I'm going to show you what our next steps are going to be in this data piece. Okay. Yes, I am. Sign into sync. Start without your data. Isn't that funny? Okay, I'm going to go for time's sake. I'm not going to go through linking this computer. Oh, here we go. This is the CDC's website for connecting the dots across different data sets and different agencies. What I really appreciate about this is that the CDC has identified risk and protective factors on an individual, relationship, community, and societal level that coordinate with these different types of violence or harm. So to use this tool, for example, I could pick sexual violence and suicide and see which risk and protective factors coordinate for both of those issues. So if I am going to be implementing a strategy in my community, this would be a strong tool to look at which risk and protective factors do I want to focus on. If I'm going to focus on the correlation between suicide or sexual violence, or even better yet, if I want my best bang for the buck, why wouldn't I click all of the dots and find out what risk factors coordinate across all forms of violence and focus on how can we prevent those risk factors. Now, since the CDC has this lovely tool for us to use, what we're going to do in South Dakota is take these risk factors or take these protective factors and link them to the available data that we have for those risk and protective factors. So that when you go to implement programming within your community, you can use this as baseline of where the information is going to be collected and how you can move forward then with your programming in ways that you can, again, best bang for your buck to use to overcome the risk factors and to beef up the preventative factors. Now, what I didn't practice is getting back to my PowerPoint. Here we go. So that's our next step. The next step of the data initiative will be happening before September of 2023 because this was funded with COVID relief funds. So that's exciting. The next series of things that we're going to go into, and I have about 10 minutes left of my presentation, so I'll go through these relatively quickly, but how are we supporting our communities to use the data to come back and increase the supports that you have? So we have a project called the Resilient Communities Project. And the next series of slides are going to go through individualized items that are happening within the strategic plan for CPCM. And they all come together over this overarching goal of what type of tools can I present to you as community members and multidisciplinary team members to implement in a way that you're looking holistically and able to really impact the child and their family. So let's start off with training and professional development. It is our goal to have baseline information out into our community. So whether you're a layperson, medical provider, a prosecutor, a law enforcement officer, you will have information about the impact of adverse childhood experiences. And since 2018, technically this number has risen. I think the number is over 20,000 South Dakotans have received training on ACEs and resiliency. The key here, that baseline information. So for me as the prosecutor, I had no idea about ACEs. I had no idea why my victim was acting the way they're acting or the defendant was acting the way they were acting. How was I supposed to educate appropriately a jury or come to an appropriate resolution for that the mother who accidentally killed her baby without having that knowledge of how we got to where they got. My goal would be to walk back into a courtroom and not have to educate the jury on the actions of people around them and the impact of trauma. ACEs and resiliency is the start of helping us get there. The Enough Abuse campaign. This is actually a problematic sexual behaviors campaign, meaning how are we educating professionals and adults around children on appropriate or problematic behaviors with children and how to intervene. This is truly a bystander intervention program. So as you can imagine with that topic, it's slightly harder to get people to want to hear about the sexual violence harms. But we have, this number I think is up to over 3,000 people trained in enough abuse. We are rolling out mandatory reporter trainings, videos. This is in coordination with the Department of Social Services and the Department of Education, but we are really getting folks to understand the value of reporting harms against a child, that engaging with the child welfare system is not bad. It's a way for you to get help and support, and we need to change the conversation from it's bad to have CPS involved with your family or bad to utilize the system to this is a protective factor that we as a community can really engage in, lean into, and help support. The Family First Act, coming from the Children's Bureau, from the national government, is strongly encouraging states, let me rephrase that, requiring states to change practices in order to receive federal funding. So strongly encouraging states to make it their practice to invest in preventative services for the child welfare system prior to the family hitting crisis and needing CPS intervention. So you will see us talking about reporting child abuse and the benefits of this over and over again, because it just plays into access to services and referral systems. We are continually training our professionals. The next three are about how we can continue to train our professionals. Having same trained, not necessarily same certified, but same trained professionals in our hospital systems may have prevented that our child number 2 from getting a physical exam when she showed up in the emergency room 8 months after, or several months after the harm had occurred. Because that professional may know that the next appropriate step would be for that child to be seen by a child advocacy center in South Dakota. Our child advocacy centers are our core to our multidisciplinary teams, and we need to be prepared to support our child advocacy centers. This training professional development will get those referral systems hopefully stronger in ways that we know how to access our partners out in the field. I'd like to touch briefly on the CAS system, because many of you in this room or online may be asked to either take part in the CAS system or to be a professional trainer in the CAS system. The Child and Adult Advocacy Studies training program is actually brought to us by Dr. Victor Beef and the Zero Abuse Project out of Minnesota. But what this is a training designed here at the University of South Dakota to show how multidisciplinary team members can work together. And when we're talking about multidisciplinary team members, we're talking about community-based response multidisciplinary team members, but we can also talk about your organizational multidisciplinary team. So why we say these two distinguishing factors is when you're working with your community-based response multidisciplinary team, that's going to be working with professionals who are not within your medical system necessarily. They may be out in the field. But what we'll also encourage you to do is to look at your organizational multidisciplinary team and say, how am I working within the Avera system, within the Sanford system, the Monumental Health or the Horizon Health Systems or IHS, before I engage with my community partners, or how is that going to look? The CAS system has 4 major components. The CAS graduate certificate does that we're super excited about. First is understanding trauma through the lifespan. The second is understanding a community-based multidisciplinary response. The third is how do we create systemic change, meaning change throughout the system through your multidisciplinary, interdisciplinary response, so that your prosecution gets stronger, your recovery gets stronger, your laws get stronger. And then finally, the 4th class is a practicum-based class where we ask you as the participant to take the learning from your first 3 classes and apply them to something that you can do in your current job or in your community. So we're activating the change through our curriculum and then providing that technical assistance while you're still a student in the curriculum. This is open to anybody who has a bachelor's degree. It's online. Look into it. It's really cool. You as a participant will help each other grow. And then you as an instructor, if we come to you and ask you to be an instructor while there is a lecture or whatnot, will also help the system grow. The school-based training. The school-based training has components. It's a 5-hour training that looks at understanding child maltreatment in children. Well, okay. Apparently it's lunchtime for this pregnant mama. Let's start over with that one. The PK-12 school-based training looks at child maltreatment as a whole and the impact of trauma on a child. Then it goes into what are trauma-informed classrooms, what are trauma-informed schools, what can your organization do. Importantly, it covers mandatory reporter training for reporting child abuse and neglect training. It covers suicide and multidisciplinary teamwork. And because of this, there is a Department of Education sponsored project to get this into every education school in the state of South Dakota so that our educators know this information prior to going into their professional careers. and then it now counts as a required piece. It can count towards your suicide certificate that you need to get, suicide training certificate you need to get every year as an educator. So big things happening there. Goal C, interdisciplinary response. We've talked a lot about interdisciplinary response, but here's where I want to focus on for you and my request out for you today. We talk a lot about how do we increase referral systems from our medical providers back out into our community. How do we strengthen that so that you know how to help your patients and their families get support? CPCM focuses on trauma screening, meaning what are we doing for screening in our practices that allows us to know if there are underlying causes for the symptoms being displayed by the children in your practice or in your exam room. This conversation around uniform screening or trauma screening led us to a bigger question of what do screening and referral tools look like in the state of South Dakota in general. I'm going to focus still on trauma screening before we get to the next referral system. But trauma screening, if your system is looking to implement a trauma screener or an ACE screener, here's my request to you. Take a look at what the other systems are doing. To my knowledge, Avera, Stanford, Child Protective Services, and there was a fourth one, all use different screening tools for trauma and different screening tools for adverse childhood experiences. If that is happening, how do you expect us to connect to our referral systems in a way that we can actually provide the services or connect that data? So in a big picture world, when I talk about end goals, it would be that we would have universal screening for childhood trauma. And I want to be clear here, this does not necessarily mean every single child gets screened for trauma. What it means is when you are screening for trauma, you use a tool that is universal. The tool in itself has similar parameters across medical systems and across the entire child welfare system, quite frankly, whether it's law enforcement, CPS, or the school system, because that way we'll start connecting our referrals. It's that idea that led us to apply for, with the support of the Department of Health, the Early Childhood Comprehensive Systems Grant. This ECCS grant is focused on children ages 0 to 3. And the entire purpose of this and why CPCM is involved is the public health model for holistic change in a family's life structure. It's that public health model knowing that we as the Center for the Prevention of Child Maltreatment want universal trauma screening. You as a pediatrician may need to look at how are your screening tools used to appropriately connect back to referrals into the community, because you as a medical provider will not be able to provide all of the services for that family to get health and welfare. So Child Protective Services also may not be able to do that, as well as the school systems. We must work together, so let's look at that. We have a 5-year approach for how we're going to look at referral systems in South Dakota for that 0 to 3 population and their families. You will be asked as pediatricians to be a part of this process. We are doing a needs analysis for the state, or a systems assessment for the state of South Dakota, which will include the funding mechanisms from the federal government into our state government for our departments, our major departments in the state. It's also going to look at the tools that we currently have, for example, the really robust and very cool 2-in-1 helpline, or the Bright Start early childhood nurse visiting program, the Bright Start nurse visiting program. How are they connecting? How is that going to look for South Dakota? We are going to have a series of interactions with our pediatricians and our family members. It's important to get the family input. And I believe it's either year 3 or year 4, we're going to be having a legislative summit to share our findings with our legislators so they're well aware of what could be inhibiting the better practice of referral systems. And that's statewide. So we're really excited about this project. It's a big undertaking, but it's the first time South Dakota has had this type of a statewide grant. We've done it, there's been one other community that did it as a community-based grant, but now we're doing it as a statewide grant. We're very excited about it. Without going into too much detail, public awareness. How can we have the hard conversations? And this fits back into the ACEs conversation, but also how are we preparing our leaders to be able to talk about tough topics such as sexual violence, childhood violence, and trauma in ways that we can have proactive change. And then the infrastructure design. Infrastructure design includes what are we doing in our tribal communities. What you see listed are items that have currently happened within our state. CPCM and our partners are continually advocating at the legislature for public health methods for impacting child maltreatment. And then for grant and research development, we have received over 20 grants and contracts with approximately $4 million worth of support. As many of you know in research, $4 million sounds great and it is wonderful. It's also a drop in the bucket compared to the needs for advancing projects. So in conclusion, I want to tell you a little bit about our staff. We actually have several of them in the room here today, but also how CPCM is working and how you can be involved with our projects. We have 8 staff focused on project management. We are not the subject matter experts. I want to be very clear about this. We are coordinating the subject matter experts. We are helping you to realize the value of your impact in your community. And we are here to help you connect your project to projects across the state, to break down those silos of work and to really build up our collective impact. We have an advisory board, which was the original Jolene's Law Task Force. The advisory board has up to 34 community members from our major departments, as well as, our major state departments, Friends of Education, Social Services, and Health, our Unified Judicial System. Importantly, that the core of that NDT, again, the Child Advocacy Centers of South Dakota and representation from each of those advocacy centers, our law enforcement officers. We have our community advocates. That's a huge piece, as well as survivors of childhood harm and their family members. That advisory board helps shape where we can make those connections across the state and really guides us on what's the next step that we can be doing to help South Dakota. And then importantly, we are funneling that information down to our students and training our students to be good public health advocates, regardless of what their profession is going to be. When you enter back out into your community, how can you give back? How can you as the medical provider be engaged, whether it's through legislative change or even just being a part of your community-based mental or multidisciplinary team. So that's CPCM structure and how we're advancing our projects. So in short, multidisciplinary teams are essential to the health and welfare of our children, and together we can make the change. If you would like to be involved with CPCM or any of the projects that we have listed today, please contact us. Not sure, there we go. Our website is on the bottom of the slide here. You'll be able to contact us directly through the website. Once you're on that website, you will have access to both CPCM's annual report and a a digital copy of that first data initiative report. So those two things are available on our website, and we do have hard copies here today. So with that, I will leave room for questions.
Great. Thank you, Carrie. Appreciate it. We'll see. I can say I have my chat open. Apparently, nobody has anything in there yet. So my first question, I'll see if anybody else is. This sounds amazing, and I'm excited for all of this and the kind of the implementation and plans. It's been a long time since I've been in the pediatric clinic, but I can certainly tell you in the ICU, we see behaviors of patients, family members who are, we would say, are behaviors that would put children at risk for ACE, or at least concerned about that. And I think the biggest issue is, where do you refer those parents to start getting help? We think, as you're trying to do that therapeutic relationship, when you say, hey, I'm calling CPS, and they're going to chat with you, or, DSS, that doesn't a lot of times turn out well. And I know that's something you're trying to change.
Mhm.
But in the meantime, we have an easy button, and Nancy and Brooke here, but what we think is good. But what tools can we use right
Yep.
now? Yeah, for
And-
pediatricians and those in the hospital.
Absolutely excellent question. The trick is making the family feel supported, right? We want the family to be able to engage with you as a medical provider and come back to you for help and support to keep that child safe. And so there are multiple steps that your internal team can do. The first is make sure that your entire team is trained on adverse childhood experiences and understanding human behavior and why behaviors might be happening. Because the more compassionate you can be towards a family, the more likely is you're going to get a better response from that family. Next, make sure that the social workers in your program are hyper aware of community-based resources. And I'll provide a very short example. I was recently put in touch with a family through as simple as a Facebook chat group. But the mom was a young mom, age 17 or 17, 18, had a child in the rural South Dakota area. Child was flown to the NICU, and mom couldn't find a ride to the NICU. And mom also had nothing at home for that baby, right? And so without that understanding of ACEs or behavior, what you might be witnessing is somebody who is hyperactive when you talk to mom on the phone, who's extremely nervous, doesn't know the language of medical systems, and is not visiting her baby. But the reality is she doesn't have any money to get there. And the family can't support buying a crib. So what is your social worker, and I'm not just going to put it on the social worker, but what is your team going to do to connect to services out in your community? And it will be different for each person's community-based practice. Because what you have access to in Sioux Falls will not be the same as Pierre, Gettysburg, Rosebud.
So that's one of the things that I've always struggled with, because having working in the NICU where we see this, our social workers might understand what's available here or somewhere, a few places, but is there any movement towards a centralization of case management?
Yes.
Please.
Yes. So there's a tool coming. There's a tool coming.
I saw the CRI and I'm like.
So there's a tool coming from the 211 helpline. So thank goodness the state of South Dakota supported funding the 211 helpline across all of our communities. But with COVID relief funds, there was an approximately $23 million grant that was written by the Department of Health to increase two services. One, our community our community nurse program, which is going to assist with some of that referral system. It's a tool, but also the second thing is the systems of care process that 211 has currently available in Sioux Falls and Brookings. What that systems of care process is connecting the services in your community with each other. So I, as the patient, could connect once with a food service, a community-based food service support, and they might take my information and put into a system that could be shared with somebody who could provide travel assistance or housing assistance or daycare assistance. And so that it's a coordinated referral service, but it's also a little bit better case management, and they will be implementing that community nurse program. Now it's complex, it will not happen overnight, and it needs community buy-in. Here's another, and I don't want to just be pointing out problems because it's the most brilliant thing that we have in our state. It doesn't connect to law enforcement. Okay, so there has to be in your community a stronger way for us to communicate as professionals. So what I would encourage you to do is whether it's your social workers or your team, to be aware of statewide programs as simple as 211 may help back in your community, or have a contact across communities who can be that bridge to the family.
Because we are a referral source, and we get babies from all across, or children from all over the state, but also from our tribal lands.
Yes.
And then we don't know. We send them back out just praying, okay, please let it be okay. But we don't necessarily always know how that's gonna go, or,
So
if
what
they don't follow up with the doctor there, we don't know,
what I would encourage is within your parameters, right? You have HIPAA that you have to be concerned about, but within your parameters, what is your community-based connection back out across the state? I would challenge that that's a responsibility for our major NICU systems in South Dakota to start being aware of, very similarly to the heart hospitals. If we're only having heart hospitals located in certain areas of our state, then they have to be able to connect people who need those services back out into their communities. We'll never overcome the issues of rurality, meaning we're always gonna have distance, right? We're always gonna have lower populations, but I'm encouraging, I guess what I'm saying is make those relationships.
So does CPS also facilitate that for the families? Like if we refer and we also set up medical care and WIC and the birth, the things that we
Yep.
can set up, will that centralized system also work with CPS? Or you're saying not law enforcement, but
To an extent, and this is where we have to understand the roles of each other within the child welfare system, because not all families will qualify for all programs. And if the financial piece of Child Protective Services does not fit for that family, then there's nothing further that Child Protective Service can do. So what's essential at that point, because the really, really hard cases are those ones that fall through the cracks. It's not a clear call for a report, or it's not a clear referral. So what we're encouraging you to do is to know at that point, because you're gonna get it. You're gonna get some family that is just falling through the cracks left and right. Where can you be the referral to a relationship back in their home community? And it's not simple. I'm not asking any one person to be the entire thing. What I'm encouraging you is, as a system, to create those relationships so that you can build those up stronger. It's not, there's no magic, right, that I can give besides understanding human behavior. And 2-on-1's coming.
I have one more really shameless plug, but I think Carolyn's also going to be on this. But we are starting our pediatric department task forces, and there is an advocacy task force. And this is a perfect opportunity for people to come and work on a multidisciplinary team, including with Carla, to kind of like work on things that they want to help across our state. So if anybody's interested specifically in this topic or others, please consider joining that task force.
Thank you. Yeah, can I add one thing to
Yes.
that? When you get into those conversations, the most surprising thing that I found across the state is that sometimes we as professionals get our blinders on, and we do not recognize some of the other good work that's being done in our communities or being done statewide. And so if you can challenge yourself to be aware of maybe your internal biases or your blinders in a way that you can take them off and be able to move forward in good progress. And I'll give a truly short example. I was involved with a grant write, brilliant grant write. It went out the door. It was lovely, but the initial narrative to me was that there is no multidisciplinary team in South Dakota working on child sexual abuse issues. So, well, that's not right. Let's rephrase that. But what was interesting is the person, again, a brilliant author who has this really cool program coming in, worked with adult issues and knew of all of the services available to adult victims and just wasn't aware of the services for child victims. Why I say that is, as you build out your referral services and you're working on this, please be aware of blinders and how we can help to make those connections for you.
Right.
Well, thank you. I don't see any other questions come up. Anything else? All right. Well, thank you again so much.
Yeah.